I'm going to talk to you about what we're calling in Yorkshire T-Health, and ask you to think about what this might enable us to do. So this is a regional programme, and as I say, the point of this presentation is just to allow us to think about what it might allow us to achieve. In Yorkshire, we're talking about T-Health having three components. The first of that is monitoring. There's plenty of monitoring going on already, lots and lots of this in the region. There's also consulting. So consulting is actually it's a virtual consultation with a doctor. And there's learn, and this is a really important piece. Learn is a mixture of education and training, both for patients and for staff. So for example, in a T-Health installation, you might want to know that the patient is actually able to use the equipment. So there's a training component. You might want that to be verifiable. Equally, you may want to deliver education to the patient about how to use a nebulizer, for example. Ditto for staff. You'd want to be sure that staff know how to use the equipment, so it's a learning component, training component. And you may want to, this is something that we've experienced in some of our work in the prisons, you may want to provide CPD to staff to allow them to extend their skills. So the three of these work together, and the umbrella term is T-Health. This is just one description of the current system that we've got in health, which isn't working. It's fundamentally broken. When we look at who comes to our clinics, 40% of the patients coming to some of our clinics are GPs basically saying, I haven't a clue what else to do. And I just need the patient to go somewhere else because I've run out of ideas. And our solution to that is to invite them to wait 6 weeks to come to see a consultant in an outpatient clinic. There are better ways of managing that problem. That problem itself is generating for us, we're a small to medium-sized DGH over towards Ilkley and Skipton, more than 1 million miles of travelling for patients coming to and from our hospital every year. Much of that unnecessary. When we look at the inpatient population, and I used to work in Leeds, and the same data holds true in Leeds, you look at the inpatient population, 30% of those patients are in the right place, good. 30% of those patients should never have been in there in the first place. They're in there for all sorts of reasons, but not because they need a hospital consultant to look after it. It might be their social situation's fallen over, it could be that they need some other kind of care, but not acute medical care. And then the final 30% of those patients we've done with, we've finished, but they're still there. And it's partly because there's no other way of managing those patients. So there's a huge amount of waste in the current system. We also know from our ambulance colleagues that 20% of all 999 calls are what they call clinically equivocal. And what that means is the paramedic goes out, has a look at the patient, runs some algorithms, and one of the questions might be, have you had any chest pain in the last 2 weeks? And the patient says no. And just before they're ready to pack the patient up and put them back into bed, the patient says, that question about chest pain, I think I might have had a twinge, you know. At which point it's game over, into the ambulance, off to hospital, into hospital. And 20% of them are clinically equivocal. And because the ambulance crews are not trained and don't practice the level of making a diagnosis, they have to take them to somewhere else. So what we've got is a system that's perfectly designed to deliver the results that it's getting, which is not good. And the result of that is that we're all under huge pressure. There's more patients than you can swing a cat at, and you've got hospitals that are super saturated, full of patients, and health economies that are struggling to pay for the consequence of this. So that's the current situation. This is a map. It's a bit out of date now, but it shows the prisons that Airedale now supports using teleconsultation. And the point of this is out of date, as I say, there are now more prisons. Over the last 5 years, we have developed a way of looking after prisoners in prisons, and the business case for this was very straightforward. 5 years ago, it was costing the prison service £21 million to escort patients from prisons to hospitals. So that's helicopters in the sky, men in vans, etc., etc. And the challenge was, could we offer a solution to those prisoners that meant they didn't have to leave the prison? And we started with Full Sutton, and we've now got prisons up and down the country. And I suppose the proof of concept is here in that over the hundreds of consultations that we've delivered, 78% of those prisoners now stay in the prisons. They don't have to go anywhere else. And against our expectations, we thought it would all be people being duffed up, you know, and all sorts of drama. And there is some of that, and we've saved people's lives remotely by directing staff in the prison to manage stabbings and that sort of thing. What's much more interesting is this is about 20 specialties worth of work, everything from a rash through to something wrong with someone's eye. All of this done remotely. The prison never leaves the prison, and the system is very straightforward and very simple. It's currently running on ISDN lines, and you have a camera in the remote end and in the centre, and you can have an interaction with the prisoner. And the doctors who do this started out by being quite sceptical. So, you know, this isn't a bunch of lunatics having a go. This is a bunch of crusty old doctors who, frankly, thought this was a load of nonsense. And I can remember one of our gastroenterologists saying, you know, I have to be able to smell my patients. This can't possibly work. And he's one of our biggest supporters now. I suppose what it also told us was that a lot of this is about long-term conditions. Prisoners are just like anybody else. They develop long-term conditions, and what we began to wonder was, well, what could we do with this if we brought it back home and started to use it for patients in our population?